Welcome back to my YouTube channel. My name is Andrea Ferrero, and I am an orthopedic surgeon with a special focus on foot and ankle surgery. Today, we are going to talk about ankle osteoarthritis, and more specifically, ankle prostheses. When we talk about osteoarthritis, we are referring to a degenerative and chronic process that cannot be improved, in which the cartilage of the joints undergoes progressive wear and tear. The diagnosis of osteoarthritis is relatively straightforward. All that is needed is a clinical examination, together with radiological tests such as X-rays, which should always be performed with the patient standing up and not lying down or sitting. In some cases, we request a CT scan or an MRI scan. Your specialist will decide which test is most appropriate. Based on these tests, we will then be able to classify the osteoarthritis, which can range from very mild to very advanced, in which the joint has practically disappeared. In these images, you can see a comparison of X-rays from 3 different patients. On the left, the X-ray shows no signs of osteoarthritis. In fact, the joint line of the tibia here in yellow and the joint line of the bone, called the talus, in red, are well apart and, all in all, parallel to each other. In the middle image, we see moderate osteoarthritis, in which the joint is beginning to collapse, with the 2 lines starting to touch. Finally, in the last image, on the right, we see very advanced osteoarthritis, in which the joint is completely collapsed and the bones of the tibia and talus are in close contact with each other. Osteoarthritis can certainly be treated, at least in its early stages, with a conservative approach. In addition to classic anti-inflammatory drugs, which should be taken judiciously under the supervision of your doctor, you can also do physical therapy and try injections which may be cortisone, but in this case, ideally, you should not have more than 3 in a year, because cortisone has negative effects. There are also other types of injections, such as hyaluronic acid, which unfortunately must be paid for by the patient, as the medication is not covered by insurance. Alternatively, there is also platelet-rich plasma injection, also known as PRP injection, which involves taking a normal blood sample and immediately centrifuging it. Part of what is obtained is plasma rich in growth factors and stem cells, which is then injected directly into the joint affected by osteoarthritis. When the conservative approach does not lead to the desired improvement, and patients are significantly affected by pain and functional limitations caused by osteoarthritis, surgical treatment may be considered. In the case of ankle osteoarthritis, the minimally invasive option, such as the arthroscopy, is generally doomed to failure. In fact, in cases of advanced osteoarthritis, it is preferable to perform a more invasive surgical procedure, which is certainly more effective in the medium and long term. In particular, I am referring to arthritis, which is the total and permanent fusion of the ankle or total ankle replacement, which, as in the case of the hip or knee, serves to maintain joint mobility. Without going into too much detail, I will show you the X-rays of a patient who underwent ankle arthritis surgery, in which the tibia and talus are locked together using a plate and metal screws. Generally, the plate and screws are not removed unless they cause discomfort, which is fairly rare. Arthritis surgery is generally recommended for people with severe osteoarthritis at a young age, in some cases of neurological diseases, or after a major trauma that, as in the case of the X-ray I am showing you, has led to severe bone loss or a significant alteration of the ankle anatomy. Ankle replacement is a surgical procedure that we now perform routinely and involves the implantation of a metal component at the tibia and another metal component at the talus. A high-strength plastic component called ultra-high molecular weight polyethylene is inserted between the two metal components. The purpose of this high-strength plastic is to allow the prosthesis to move without the two metal surfaces touching each other. Since metal material is being implanted, please inform your surgeon if you are allergic to nickel, which could increase the risk of rejection of the prosthesis by the bone in which it is implanted. Anesthesia can be general, known as narcosis, or better still, spinal anesthesia, which involves an injection between the vertebrae. Spinal anesthesia not only has the advantage of being less invasive for the heart and lungs, but also has the advantage of avoiding post-operative pain. In order to prolong the anesthesia as long as possible after the operation, anesthesia is also administered to the thigh or calf. The surgery involves the use of a wide range of instruments. These include instruments for cutting bone and components for testing the two metal parts and the plastic part inserted between the metal components. The test components are important for confirming the perfect fit between the prosthesis and the bone surfaces, but also to verify the stability and the correct tension of the ligaments around the ankle. In addition to this wide range of surgical instruments, the most interesting part is probably the one that is tailor-made for the patient, which helps us to position the cutting instruments exactly according to the preoperative plans. Preoperative planning involves performing a CT scan, the images of which are then sent to the prosthesis manufacturer, who in turn enters them into a computer program through which the surgeon can decide in advance the direction and position of the cuts and also the size of the prosthesis. Once the project has been planned, the manufacturer will then print a model using 3D printers. This model will then be used in the operating room to position the metal wires through which we then insert the cutting guide. You must consider that in order to insert the prosthesis, we must necessarily make cuts in the bone, both at the tibia and at the talus. These cuts are made with a high-speed saw, using the grooves in the cutting guide. There are 4 cuts, 2 horizontal and 2 vertical. While we use the saw to cut the bone, we irrigate with water to cool the local temperature caused by friction between the saw and the bone. Once these first 4 cuts are complete, we can remove the bone that is still attached to the surrounding ligaments and gently free it with a scalpel. Finally, we obtain a free space in which we will position the prosthesis as planned preoperatively. However, the 4 bone cuts are not sufficient. In fact, we still need to remove more excess bone at the level of the talus. It is essential that the bone cuts at both the tibial and talus levels correspond perfectly to the shape of the prosthesis that we will insert later. The cuts to the talus take longer and are more complex than those to the tibia, as this bone has a much more complicated anatomy. After completing the final cuts, we are ready to use the trial components. In other words, before inserting the final components, we want to assess the mobility and stability of the prosthesis with temporary components that are inserted one at a time and allow us to verify that the cuts are as correct as those planned before the operation. In addition to the clinical evaluation that the surgeon performs to verify the mobility and stability of the prosthesis, X-ray checks are also performed with a low radiation device. However, I would like to point out that the same X-ray machine was also used before this moment to ensure that, step by step, the bone cuts were performed correctly Only at this point can we finally confirm the dimensions of the prosthetic components, which are then inserted one at a time. The ankle prosthesis is essentially a cementless prosthesis. In other words, it is a prosthesis whose stability is guaranteed by the perfect fit between the bone cuts and the inner part of the prosthesis itself, which is inserted by pressure using a small driver and a hammer. One of the characteristics of cementless prostheses is that they have a very rough inner surface, like a sponge, which allows the underlying bone to grow and therefore adhere to the inside. Once pressed into place, the components of the immediately guarantee ideal stability on the bone. We have now reached the point where we have inserted the two metal components and must now insert the last component, the plastic one. Again, we first use the trial component and only then the final one. We generally start by using the thickness of the trial component as planned on the computer. However, to ensure that the component is the right size and thickness, we also try the larger and smaller sizes. Every time we insert a component, we test its stability and mobility. Based on the mobility of the ankle and the tension of the ligaments, we then choose the final component to insert, which is almost always the one decided upon during computer planning. After choosing the plastic component, while the instrument technician opens the sterile package, the surgeon and assistant wash thoroughly to remove any microscopic tissue debris. After this final test of the plastic component, we can finally use the final component by using this pressure tool, into which we can gradually insert the high-strength plastic component. The procedure is practically complete, so we can close the deep tissues using a resorbable suture, i.e., made of material that will dissolve spontaneously over the course of several weeks. For the skin, on the other hand, we usually use this system, which resembles the metal staples we normally use to fasten sheets of paper. These metal sutures will need to be removed after 2 or 3 weeks, depending on the stage of skin healing. It should be noted that there are some patients, such as diabetics or heavy smokers, in whom skin healing may take longer than expected in the normal population. After applying a sterile bandage, a cast, or more frequently a long boot brace is applied, on which patients can immediately put their full weight. The first dressing is changed 5-7 days after surgery. During this time, the patient will remain in the clinic. At the end of each dressing change, the long boot brace is put back on, and you can walk using 2 crutches. In this case, you can see how the patient, 2 weeks after the operation, is able to put all her weight on the leg, with virtually no pain in this case, but this is an exception. The patient had to stay in the clinic longer than expected because she could not return home. After surgery, it is essential to follow a few basic rules. For smokers, in order to reduce the risk of wound suffering, it is important to try to limit nicotine intake as much as possible. The most important rule is to always keep the operated foot elevated to prevent swelling. Even just sitting with your foot pointing towards the floor is inadvisable because the swelling can cause not only pain, but also suffering of the surgical wound. If you keep your foot elevated at all times during this initial phase, the pain will also be very mild. In fact, many patients stop taking painkillers regularly just a few days after the operation and only take them when necessary. Generally, for the first 2 weeks, I recommend not putting your full weight on the operated foot. After that, you can put your full weight on it depending on the pain, using 2 crutches if necessary, and always using the long boot brace that I showed you earlier. It is absolutely forbidden to get the wound wet until the metal stitches have been removed. If necessary, you can use waterproof bags available from pharmacies, ideally reinforcing them with a layer of cling film from the foot to the knee. Even if you have an automatic car, it is best to wait until the boot is removed about 6 weeks after the operation before driving again. Physiotherapy generally begins 2-3 weeks after the operation. In the early stages, physiotherapy will aim to reduce residual swelling by performing lymphatic drainage and beginning to actively and passively mobilize the ankle. In a second phase, physiotherapy will be essential to strengthen the muscles of the operated limb and to resume walking correctly. This is the same patient whose images I showed you earlier. We are now 1 month after the operation. This is the first time the patient has tried to walk without a brace, and as you can see, she is able to put her full weight on her foot without complaining of pain. Obviously, she will have to continue with physical therapy, which will clearly aim to re-educate this lady to walk better. Surgery, understandably, carries risks, such as infection. In this case, it is advisable to quickly perform a surgical cleaning of the prosthesis by replacing the plastic component. Samples must also be sent to the laboratory to identify the germ responsible for the infection, which will also provide a list of antibiotics to which the germ is sensitive. Antibiotics should be started as soon as possible in the event of infection and continued for several weeks. However, the risk of infection is very low, less than 1%. Another risk is deep vein thrombosis, which is the formation of a blood clot that can form in the operated leg. To reduce this risk, it is essential to perform a small subcutaneous injection with low molecular weight heparin, which is safer than anticoagulants taken by mouth. Low molecular weight heparin injections must be administered for the first 4-6 weeks after surgery, or until you stop wearing the long boot brace. As with any surgery, swelling may remain localized for much longer than expected. This is certainly true in patients with chronic renal failure, or even more so in patients with venous insufficiency. In case of swelling, it is definitely helpful to keep the foot elevated, apply an ice pack several times a day for 10 minutes at a time, and undergo physical therapy, in particular to perform lymphatic drainage. Swelling, in addition to causing painful symptoms, is also one of the causes of skin healing problems. This is certainly an even more significant problem in at-risk patients such as smokers and diabetics. Another risk is joint stiffness, which generally improves progressively with physical therapy. However, it is possible that over time, the overall mobility of the ankle prosthesis may worsen compared to what was achieved in the operating room. Overall, it is rare for this possible loss of mobility to be a source of discomfort for patients. Another possible complication is persistent pain, which can sometimes be linked to the prosthesis failing to bond to the bone. This detachment of the prosthesis can be infectious in nature due to an infection, theoretically even of a low grade, which means not clinically evident, but it can also occur without a real infection. In this case, we call it a septic detachment. If the detachment causes pain, it may be necessary to remove the prosthesis and implant another one, or to perform arthritis, which is the surgical fusion of the joint after removing all the previously implanted artificial components. If you think this video was helpful, or if you think it could be useful to someone else, please like and subscribe to the channel. Thank you.